SRC, Dr. Letlhogonolo Makula. Colleagues, this is a very important occasion for us because the HSRC survey, what we used to call the HSRC household survey in the past, has been, one of the most important reports for us as the provincial response, because it is through this report that we are giving strategic information in terms of how we need to go about implementing our activities within the province. Colleagues, I have one of my colleagues who has been allocated the responsibility of welcoming all of you, including our guests from HSRC. So at this stage, colleagues, I would like to call upon the Director and Head of Secretariat for Gauteng Province, Ms. Nolundi Mfecane, just to welcome all of you and basically also indicate why we invited you to this occasion today. Once that is done, colleagues, I will then hand over to my co-driver, Dr. Makula, to take us through the proceedings for the day. Thank you so much. Ms. Mfecane.
Good morning, colleagues. Am I audible? Is it fine? Must I use this one? Oh, okay. Good morning once again to everyone. Am I okay now? Okay, apologies for that. And thank you very much, Mr. Motolo, for that introduction. My name is Nolundi Mfecane. I'm the head and the director of the Gauteng AIDS Council Secretariat. And thanks to HSRC and to the team for organizing this workshop, which is a very valuable workshop, which will also pave way for us, as the province. My role is a very simple one. It is just to do the opening remarks and to welcome everyone in the room. And I would also like to acknowledge the presence of my boss, the acting COO for Gauteng Department of Health, Dr. Selebe. If I don't acknowledge him, I might end up not getting my paycheck at the end of the month. So that I have to do over and above welcoming everyone. Colleagues, I would like to acknowledge and appreciate the presence of the entire team led by Professor Zuma from HSRC. I would also like to encourage and acknowledge all the stakeholders that we're working with in the province, from government departments, more especially the cluster departments, Department of Health, Department of Social Development, Department of Education, as well as other key departments that are responsible for the multi-sectoral response in HIV, TB, and STIs. I would also like to acknowledge one of our key stakeholders, the Civil Society Forum, which is led by Ms. Gladys Chabalala. Ms. Chabalala, if you can just raise so that everybody can know who our chairperson in the province is. And everyone else, colleagues, that I've not mentioned, you are all welcome. All protocol is observed. As the head of Gauteng AIDS Council Secretariat, just for the benefit of everyone in the room, we have got the Gauteng AIDS Council, which is led by the Premier as the chair and co-chaired by the leader of civil society, in our case by Umamu Shabalala. So as the Gauteng AIDS Council Secretariat, we are the administrative arm of the Gauteng AIDS Council, meaning all of you in the room, you are very important stakeholders in ensuring that we do have a functional AIDS Council in the province, whose main responsibility is to ensure that we curb, the HIV and STIs, TB and STI infections. And as a province, we are also in the process of establishing the Provincial Private Sector Forum, which is the PPSF, that is in the pipeline. And you will still know that we've got those key stakeholders part of us as the AIDS Council. Currently, we've got the National Private Sector Forum at SANAC, and we are going to be mimicking that same model from SANAC throughout all the provinces to make sure that we bring the private sector on board in all provinces and we actually work closely with them. More especially because there is a need to work with private sector in some of our districts, more especially those that have to do with the mining community. We are also responsible as the AIDS Council in ensuring that we do capacity building of all our stakeholders. That process is ongoing, more especially with regards to issues of M&E, as we will also see when the reports are being presented, and as well as program management, because we work with a lot of sectors of civil society. So we do capacity building, more especially with them, so that they understand and are able not to only put the figures when we do the monitoring visits, but they actually synthesize the reports so that at the end of the day, we've got meaningful reports. HSRC has come at the best time for us as we are preparing for the World AIDS Day 2024. And we hope that this report will also help us to identify areas of concern and areas where we need to strengthen our efforts, and the districts, that need attention in terms of strengthening their interventions towards HIV, TB, and STIs, such as teenage pregnancy as well as condom usage challenges, more especially with regards to the youth. We'll be hosting a teenage pregnancy seminar soon, now in September, which will be focusing on that, targeting the youth. As HSRC, we are all aware, they are Africa's largest dedicated social science and humanities research agency and policy think tank. So they will, during and after their presentations, and findings, they will be the ones who will be best suited to ensure that they explain all the inconsistencies that some of us, as we are seated here as the stakeholders, will pick up from their report. And based on the survey results, we hope each and every one of us here in the room will find space and will be able to see where we fit and where we need areas of strengthening and our areas of focus from what will be presented today. And also what we need to prioritize as with regards to the program implementation, as we are all intending to have ending AIDS by 2030. On that note, Chairperson, I would like to welcome everybody, and we're looking forward to the engagement interactive session. Thank you.
Thank you so much, Ms. Mfecani. There you have it, colleagues. I think the director has, did a very good job in terms of putting us in the picture with regards to why we are here today and what is expected. Colleagues, I did indicate that I'm not alone. I will be co-facilitating with Dr. Makula, who will now take over just to take us through the proceedings for the day. Thank you.
Thank you so much, Mr. Mutolo, and thank you to your team for the work that you have done to get us here, and also the warm welcome from the director and her office as well. We really feel welcomed as the HSRC and the partners that are involved. So I also just wish to extend our greetings to the colleagues that are connected online. So as we interact in this room, we also note that there are people that are also part of these discussions. I'm also observing all the protocols here in this room and also online, so that we don't identify individuals that and leave out others. So we are just overall happy that we are here. So I'm just going to start off by just giving us an overview of the program. It should be in your table. It was in your folder. So if you have not found it, we can just let us know. There is an HSRC representative on a table that can just assist you. So we are just going to just get an address from our partner, CDC. Ashley Boylan, who's the Quality Improvement Team Lead, will just address us on behalf of Dr. John Blandford. From there, we are just going to go directly into the HSRC presentation. Prof. Kangalani Zuma will lead the team as they share the findings from Gauteng, including the specific districts where we oversampled. And then we are going to allow you colleagues to reflect on the findings. So as I've mentioned, there are people that are from HSRC and partners that are sitting with you in the table that are meant to also guide these discussions. We have a few questions and we want to know, how do you relate to some of these issues that we would have shared? In as much as we are here to share with you the findings we have, we also want to understand what is happening in the province and what are we doing and what are the lessons that we can learn. We then are going to ask a representative from each of the table to just share what are the issues that were raised or discussed in that room, just for us to also have an understanding. So each table will sort of discuss different questions so that we're able to cover as much as possible. We are hoping to only have lunch after we have had an address by Dr. Slepe, so and hopefully we'll be able to catch up on time, noting that colleagues still have a bit of travel to do. So that is just the summary of the program. So when we after registration, I think we just asked colleagues to go and reflect on the photo exhibition that is at the back. It was also displayed just for you to just have reflect on the journey that South Africa has gone through in relation to HIV. And what we also did was to ask you to then log on or scan the QR code, because we wanted to also just hear from you. How are you reflecting when you look at these pictures? What emotions, what thoughts come from you, just to start off our day? So what we are going to do is just to also get just the reflections that you would have noted down. And before we do that, I don't know if we can just give, because I'm seeing colleagues that are just working in while our IT is preparing that, just to give colleagues 5 minutes to just introduce yourself to the person that is sitting next to you. You note that we pre-selected you just so that we diversify the discussions that we would have, but also to just also allow you to speak to someone that you don't always work with. We know that in most cases we work in silos. We don't have an opportunity to exchange, even though we have the same goal, we sometimes do the same work. So it will be a nice opportunity that the day that you are spending with us, you also network and also exchange ideas on how we can strengthen the work that we do. So we'll just allow you that 5 minutes. And while you do that, those that have not yet completed the first question on the expectation for the day, they will do that so that we have them on our records and then we can reflect that. I think the director set the tone well in terms of what the office expect from today, the type of discussions and what they anticipate will also give responses to, right? So we want to hear from you. What is it that when you were invited here and as you were driving or walking in, what are the thoughts in terms of when I come out of that discussion, what is it that I want to have received, or why am I going to attend this event? So it will be lovely that you are able to do that. The second question would obviously be what we discussed around the pictures. And then the last question is around your interests. What is it that makes you unique? We want to see how unique you are, or if we are really the same. So we're just going to allow that 5 minutes for the quick discussion and to get assistance in terms of ensuring that you are able to log into Mentimeter. And then I'm seeing someone that is saying toilet. So for those that don't know where the toilets are, so you just come out of this room, you turn right again, and then you'll see the signs so that we are able to go in and quickly come back. So that 5 minutes, Tsietsi, then we should be able to then see the reflections. Yeah. Yeah, u kana wa display, ne? Okay, colleagues, thank you so much for the. Okay, so the idea is that even during lunch we can continue the conversations that we have started, ne? So we'll just the hugging, everything. Colleagues, hi colleagues. These conversations are starting today, but they're not ending with the event, ne? So the idea is that we're exchanging numbers, we are connecting, and then we'll chat more during lunch, during breaks, and even take the conversations into the offices where we can then meet there. So I'm just going to allow Tsietsi to read through the responses from the first question, which was on what, okay, thank you. So the first question looked at what your expectations for the day, for today's programs were or are. So Tsietsi will just go through some of the most captured responses.
Thank you so much, Dr. Makula. So, colleagues, some of the key responses to this question include one, latest research on youth, identifying strengths, gaining more understanding. Some of you are expecting active engagement as well as insightful feedback. So you can see, colleagues, that there is a lot of emphasis on really engaging with the data that will be shared today. So I won't be going through all of them, Dr. Makula, but in a nutshell, there is an expectation that there's going to be an engagement with the data that will be shared. And obviously, we are expecting to learn from everyone as well. Thank you so much.
Thank you so much. I see one that said energy, so I'm not sure as to whether the energy in the room or what energy means. So let's just move on to the second question. So on the second question, we looked at the gallery that was shared with you and would like to thank Dr. Sahir Parker and Senek who curated these pictures that we have just to reflect on the journey that we have been through as South Africa in relation to HIV. And these are some of the reflections from the tables.
Thank you so much, Dr. Makula. So the exhibition, colleagues, made some of you feel that we have come a long way. Some of you felt nostalgic. It made you feel good and excited. Some reported mixed emotions. You reported being optimistic about the future. The exhibition was thought-provoking and it guides program plans. And it also includes all the sectors. So that is basically, the nutshell response that we have received with regards to this question.
Okay, no, thank you. And moving on to the last question, that would be the most easiest question to respond to, or even difficult for some colleagues that don't know yet what they would regard them as unique about themselves. So,
Yeah. Thank you, colleagues. So with regards to what makes each one of you unique, people have responded that humility, qualities like being inquisitive, curiosity, being enthusiastic. People love cooking. People love traveling. There's one person who's an adrenaline junkie. So we really want to see that energy today. Some feel that they have been chosen and called. Yes, that's why we invited you here. People are passionate, about being young. They are interested in community development.
okay.
Thank you.
So the one that says my beard, I'm trying to look at who has the beard that could be making them unique. So, but that's, I mean, you need to nurture it and so forth. So I guess it is unique about yourself. So moving on into more serious issues, colleagues, we are going to start off with an address and a welcome on our side from our partner, CDC. And on behalf of Dr. John Blandford, Ashley would be giving the address. Thank you.
Thank you. All right, good morning, ladies and gentlemen. Ooh, this one's very loud. Everyone awake now? Good morning, ladies and gentlemen and esteemed colleagues. My name is Ashley Boylan. I'm the Senior Advisor for Quality Improvement with CDC South Africa. I'm standing in for Dr. Jan Blandford today. He is our CDC Country Director and sadly cannot be here today, but does send his apologies. First, I would like to begin by recognizing our colleagues in the Department of Health, Department of Social Development, Department of education, SANEC and the AIDS Council, and the many diverse representatives from civil society. Ladies and gentlemen, all protocol observed. First, I would like to congratulate the HSRC, its partners, and the government of South Africa for the 6th National HIV Household Survey, and for the impressive legacy of leading HIV surveys in South Africa for 20 years. The SABSSM survey is led by South African scientists to improve the lives of South African citizens. The results demonstrate how key investments in partners and institutions have established a legacy of country-owned data, infrastructure, and the capacity to respond to current and future health threats. This scientific legacy of South Africa is renewed around the world. All eyes look to South Africa to lead. We at the Centers of Disease Control, CDC, are proud to have collaborated with the Human Sciences Research Council on this important survey. This collaboration, spanning nearly 20 years since 2005, as you've seen in that timeline in the back, has been made possible by funding from the US President's Emergency Plan for AIDS Relief, otherwise known as PEPFAR. The findings at the national level are encouraging and demonstrate how South Africa's policies and programs has contributed to stabilizing the HIV epidemic. And I think if you reflect on the photos in the back, we all remember a time where this was not stable. It was crisis, and we have moved beyond that. We are seeing increasing levels of population viral load suppression and promising trends in HIV prevalence and incidence among young girls and adolescents. But we're not done, and we're not there yet. The survey results and the data generated by it has helped us understand where we've made great progress, but also areas we need to focus on in the future. With this information, we can strengthen our programs and tailor them to people who need it most. Data is knowledge, and with knowledge comes great responsibility to respond, to adapt, and to improve. As we discuss the SABSSM 6 survey today and the implications for the HIV response here in Gauteng, it is important to remember where we came from. Just 20 years ago, from a time that there was no treatment, and it was much more despair than hope. We now have highly effective treatment. For a majority of people, 1 pill once a day. This treatment, ART, not only improves lives and families and communities, but we also now know it prevents the spread of HIV. This is the foundation of U equals U. Undetectable equals untransmittable. A person on ART with a maintained undetectable viral load has 0 risk of transmitting HIV to others. 0 risk. How amazing is that? We would never have thought about this 20 years ago. And look how far we've come, and I think this is today a celebration of that progress. I'm especially proud to be standing here today in the province that is truly leading the way, Gauteng. Just recently, yes, thank you. Just recently, they had their U equals U workshop in July, and they have fully adopted the science behind equals U and endorsed the 0 risk messaging. We are also excited that Gauteng has been one of the first provinces to develop a robust U equals U implementation plan, which will be rolled out and supported from our PEPFAR partners. Thank you, Gauteng, for leading the way. We need to focus, though. We need to focus on those who do not know their status, those who are not on treatment, and those that are not virally suppressed, because these are the drivers of new infection. And we need to find them and help them to not only get them on treatment, but this in turn then helps their families and communities to thrive. Those who are on treatment and have done the work to be virally suppressed should be loudly celebrated, not stigmatized. They have taken personal action to stop the spread of HIV. And finally, I must acknowledge and thank the over 5,000 residents of Gauteng province who contributed to the SABSSM 6 survey by opening their doors to HSRC teams and participating in the survey. Your willingness to share helps all of us provide better care. The end of the AIDS epidemic is in reach, and together we are stronger, and together we can see an AIDS-free generation. Thank you so much, and I really look forward to today's dialogue.
Thank you so much indeed, and there's so much to celebrate and so much to also still work on. With that, colleagues, I just want to welcome Professor Kangalani Zuma from the HSRC and his team that are going to share and launch these findings that are specifically for Gauteng, the colleagues that are working in Gauteng, the residents of Gauteng as well. So as he finishes, we'll also introduce colleagues that are going to join him and share the presentation with him. Just a warm welcome to Professor Kangalani.
Okay, colleagues from the Office of the Premier, Department of Social Development, colleagues from NDOH, the civil society, our partners, CDC, ladies and gentlemen, all protocols observed, good morning. It's really a great pleasure for me to be given this opportunity to be taking you through the results of our very important study, the South African National HIV Prevalence Survey, where we'll be focusing on the Gauteng province. Obviously, when we present the results, colleagues, can I confirm that I can be heard at the back there? And here? Okay, now I just need to check that. And online I can be heard. Okay, thank you so much. So I will be taking you through the results, colleagues, and we'll be focusing on Gauteng. But obviously in doing that, we'll be placing Gauteng in relation to the national statistics and also in relation to other provinces, so that we can see where we are going and how we are moving in dealing with the HIV epidemic as the people of Gauteng. Let's see. Now, our presentation, colleagues, as indicated, I'll give you a bit of background of this HIV prevalence survey, provide you with the key objectives, and also some indications of where we're coming from with this survey, and then present you the provincial results. We'll look at the response rates, and also some results on the HIV prevalence, both at national and at provincial level, and also at district level. That's one of the very important aspects of this study, that the results, we don't only present results at provincial and national, but we go down to the districts. And we'll talk about the levels of viral load suppression, as my colleague has indicated, the importance of being virally suppressed. So we'll talk about where we are in that aspect. Colleague, this is a study that was first implemented at a time whereby you could never imagine us talking about living a happy life with HIV. This is a study that was implemented at a time whereby being infected with HIV was synonymous with getting a life sentence, a death sentence actually. I think a life sentence would be better. So, well, not at correctional services. I'm sitting next to a colleague from correctional services. So the study has expanded in scope and started from 2002 up to 2022 today. So we are implementing the 6th survey today, and this study was first actually pioneered by our former president, Dr. Mandela, and the funding of the first study was actually obtained from the Nelson Mandela Foundation. So from 2005, we had our partner CDC joining us, and CDC has been with us since that time, and we're indebted to them for the support that has been provided. The study has expanded in scope in the sense that at the beginning we were getting into a number of households and interviewing a sample of people within each household, whereby at some stage we're interviewing up to 4 people within each household. But now once we get into a household, we invite everybody to participate in the study. The study has increased also in scope in the sense that we no longer only provide results at national level or provincial level, but we collect sufficient data to be able to present results down to the district level, up to 33 districts, as you will see in a minute or so. So the study has been a major source of information for measuring the progress that we are making towards the target and the goals of our National Strategic Plan for HIV, TB, and STI. And we have also increased the biomarkers depending on where we are with the epidemic. We increased the biomarkers so that we are able to collect information that will help us understand where we are with the epidemic at that particular point in time. So as indicated, the main objective is to be able to provide estimates of HIV prevalence at national level, at provincial level, as well as at district level. So a sample of districts, not all districts in the country are covered, but a sample of districts are actually covered. We also provide estimates, to be able to provide estimates of the proportions of people that are on treatment, so that as a country, we know how many people who are out of how many people living with HIV are actually on treatment. And of those on treatment or even not on treatment, how many of them are virally suppressed? So the statistics we're able to provide. Another important statistics that we are able to provide is HIV incidence, which is a very important statistics because it provides us with the rate of new infections. So that is HIV incidence. If we start at the beginning of the year, for example, with a number of people that are HIV negative, how many of them by the end of the year would have seroconverted and became HIV positive? So that is the incidence, the rate that gives us the most recent infections compared to HIV prevalence, which is just the cumulative number of people living with HIV. Now, one of the challenges with this most important statistics to present is that for us to be able, as you can see, we only provide that statistics at national level. The reason is for us to be able to provide that statistics even at lower level, at more granular levels, we will need to have many people getting infected with HIV so that we can be able to do the calculations as statisticians. The fact that we don't have the large number of people for us to estimate result or provide results at that lower level, on one hand, it's a good thing because people then are not getting infected. But it's a bad thing, obviously, for people who are interested in statistics. So that is why we're only able to provide at national level because we don't have sufficient number. Otherwise, we'll have to have so many people seroconverting for us to be able to estimate that at that level. Now, in summary, how is the study designed? So the study is stratified by province. That means in each province, we have, or let me say in the whole country, the country is divided into small geographic communities that are called small area layers. And these small area layers, it's a database that is hosted by Statistics South Africa, which has about 250 to 350 households in each of the 84,000 geographical communities in the country. So wherever we are, even where we are here, we belong to a particular small area layer. Then for this survey, we randomly select more than 2,000 small area layers for us to be able to provide sufficient statistics at lowest level. In each province, we go to each province, all the 9 provinces are included in the study, and within each province, we go to a sampled number of districts. Now, some of the districts have been identified where we collect sufficient information so that we are able to report these results. These are 27 PEPFAR priority districts, and over and above that, we went to 6 districts that were identified by NDOH as priority districts. So we're able to provide results down to about 33 districts in the country. Funding permit, it is my hope that in future we'll be able to cover even more districts. Data was collected among all people living in the country of all ages from January 2022 up to April 2023. Now in Gauteng, we expected that a total of over 11,800 people will participate. So this is the map indicating each dot there is the small area layer. So it indicates it represents about the 250 to 300 household area of that has those households. So that's just the distribution of where the team did go to collect this information. In each of these small area layers, we then randomly selected 15 visiting points, a cluster of 15 visiting points. These are households, the group of people that are living together in each and every one of these small area layers. And then within each household, we invited everyone to participate in the study. Now, once we get into a household, we have a questionnaire that we administer. We seek permission from the head of the household who will provide us permission to continue with the study. Once that questionnaire is completed, where we do a listing of all people living in the household and we collect some information about the household situation, we then administer at most 3 different questionnaires depending on the ages of people that are there in the household. Well, at least I would say. One questionnaire, we call it a parent questionnaire or a guardian questionnaire. This questionnaire is administered among young ones that are 0 to 11 years, and that questionnaire is responded to by the parent or a guardian on behalf of the child. Then we have another questionnaire, which is a 12 to 14, that we administer to the child himself or herself, whereby the child responds to the questions. Within that questionnaire, we have some behavioral or sexual behavioral questions that we ask. And then the next more detailed questionnaire is the 15 years and above. With this questionnaire, that is where we collect a lot of detailed information about sexual behavior. This is the detailed CAP survey, the knowledge, attitude, perception, and behavioral part of the survey. Now, once people have agreed to complete the questionnaire, we then invite them to provide a blood specimen. And so that the blood specimen that we collect, we can combine it with the behavioral information, and that is the essence of these second-generation surveillance surveys, that we combine behavioral information together with the biomarkers. Among children, we use a heel prick among those that are younger than 24 months to collect blood, and then we do spotting on the dry blood spot, which is what we take to the laboratory for further testing. And the list of tests that we do, one is that we test if a person is living with HIV, and of course we do confirmatory tests to confirm that those that are negative are truly negative and those that are positive are truly positive. Once a person has been tested to be living and found to be living with HIV, we then do another test, the incidence test, among those that are 2 years and above, so that we can test whether the person was recently infected or it's a long-term infection. It is those results that we use to actually calculate the annualized estimate of HIV incidence. The other test that we do is ARV test, where we test whether people are actually on ARVs. Another one is the viral load test, where we test whether, or the levels of a viral load, which is what we use to indicate whether a person is virally suppressed or is not virally suppressed. So those that have less than 1,000 copies, they are indicated to be virally suppressed, and if the viral load is higher than that, then that person is not virally suppressed. Now, what are the results? Or should we skip this part? Okay. Okay, so now, colleagues, in Gauteng, we went to over 3,000 visiting points. So went to over 3,000 visiting points, and of those visiting points, obviously some of them would be household and some of them would be business institutions, and the focus of this study is a household-based survey. Of the 3,190 households, 94 or 95% of them were found to be valid. So these were households where there were people that were living in. And of these valid households, 70% of them agreed that we can complete a questionnaire. And within these households, we found that 6,034 individuals of all ages were eligible to participate. And now you can see that of these 6,000 people, 92% of them agreed to be interviewed. So this shows an indication that once our data collectors are allowed to conduct interviews, they stand a higher chance of encouraging people to participate. The challenge is usually at household level, especially in areas such as Gauteng, where there are gated communities and affluent societies, people not wanting anyone coming into their households. So all of us here, we have a responsibility of finding ways to encourage people to participate in these surveys, especially as we prepare a funding permit, as we prepare to do other surveys. So household response rate, improving a household response rate is one of the areas that we need to strengthen as a team here. Now, again, you can see here that females were more likely to participate in the study compared to males. And overall, 60% of those that provided agreed to be interviewed. They also agreed to provide a blood specimen. Again, we need to improve that part. Nevertheless, women were more likely even to provide a blood specimen compared to males. So we need to encourage males to participate in these studies. So we need to do a lot more work to encourage males to participate in these studies. We need that information. Now, coming to HIV prevalence, where are we? As a country, the prevalence of HIV was 14% in 2017. In 2022, the prevalence was 12.7, so it went down. Now, we need to be cautious when we interpret statistics such as this, especially the prevalence, which is a cumulative number of people living with HIV, because there are a number of factors that could contribute to either increasing in prevalence or a decline in prevalence. One of them, the prevalence of HIV, for argument's sake, if people living with HIV were to die at a higher rate than those that are not living with HIV, then the prevalence of HIV would go down. On another hand, if, for example, more people are born HIV negative, population growth, they are born more, if more people are born HIV negative, then the population of HIV negative people will increase, and therefore the prevalence of HIV will go down. On the other side, if there were to be no population growth, people living with HIV not dying because people are on ARVs, people living longer, then the prevalence of HIV actually would stay the same. It will not go down, it will not go up. So we always need to look at what are the factors that contribute to this increase. Now, looking at Gauteng, the prevalence of HIV, in 2017, it was 12.1%. In 2022, the prevalence of HIV mathematically went down to 11.9, but statistically, it did not change. It's funny for a Zoomer talking about numbers. So, the prevalence of HIV in Gauteng did not change significantly. It went down from 12.9 down to 11.9%, but that is not a significant statistical change. Now, what does this translate to? This in Gauteng means that a total of 1.7 million, or just over 1.7 million people were living with HIV in year 2022. More than 1.7 million people live with HIV in Gauteng. And this statistics is slightly lower than what we saw in 2017, where 1,780,000 people living with HIV in 2017. So you can see that there is a change, but it's not a statistically significant change. Now, looking at the epidemic profile of HIV here, we see that among younger people, we see this is the 2017 curve, and this is the 2022 curve. Among younger people, you can see that the prevalence is lower in year 2022 compared to 2017, which is an indication that there were fewer HIV infections in 2022 compared to 2017, because the prevalence has gone down. If you look among older people, you can see that the epidemic is actually aging. People are living longer. Why? Because in 2017, this was the curve here, but in 2022 it has shifted towards the right-hand side. This you can only realize when people are living longer, and we know that one of the contributing factors is people being on ARVs. But here is, and again you can see that the peak in 2017 was 31.2 among those that were 35 to 39, and that peak has shifted towards the right-hand side. It's now among the 50 to 54-year-olds. So in a way, it's a good thing that people are living long with HIV. But here is a slight concern. The peak in 2017 was 31.9. But the peak in the following survey year was 32.2. It's increasing. This could only be realized, this increase could only be due to people, most likely, who were HIV negative in 2017, but becoming infected few years later. And that is something that we need to be concerned about. However, people are living longer with HIV compared to the previous years. Now, coming to overall HIV prevalence by demographics, again, we can see the graph still shows that women still at higher risk of HIV infection compared to males. And obviously, one of the things that we know about HIV epidemic is higher risk of HIV infection from males to females than other way around. That could be the most contributing factor. HIV prevalence generally higher among females compared to males. And also people in the rural areas, the prevalence was slightly higher, was the highest among those that were in the rural formal areas in the farms, followed by those in urban areas, and then the least among those that were in the informal or rural informal or tribal areas. Now, by district, the districts such as City of Johannesburg as well as Sedibeng are the ones that have the highest HIV prevalence. Compared to others, the ones that are in the lowest range would be Tshwane, for example, at 11.6, and then the highest being your Sedibeng at 13.2, followed by City of Johannesburg at 12.9. Now, again, the prevalence could be higher, but we need to look also more into the proportions of people that are on ARVs in those districts, and also the levels of viral load suppression, because that is what we also need to monitor very closely. How about proportions of people with, who are on ARVs? In Gauteng is the province that shows we see an increase from 2017 of people that were on ARVs from 56% up to 73%. However, compared to other provinces, that's the order. The province that had the highest proportions of people on ARVs is KwaZulu-Natal. The province that has the fewest proportionally people who are not in absolute numbers, in proportions, people living with HIV who were on ARVs was in Gauteng. So there's a lot more that we need to do to improve that statistics. Remember, our target, it's a 95, 95, 95 target, as my colleague is still going to show us where we are at, in Gauteng. So this has to improve, because it says to us, actually, almost 500,000 people, 500,000, almost 500,000 people in Gauteng who are living with HIV, out of the 1.7 million people are not on ARVs. Now, when people are not on ARVs, would be worse in terms of viral load suppression. So we can see where we need to go and have an impact on. We need to find those 500,000 people. We need to work hard. Let's get them, let's put them into treatment. So 500,000, almost 500,000 people not on ARVs out of 1.7 million people living with HIV in Gauteng cannot be accepted, colleagues. Now, about antiretroviral treatment again by age groups. Now, if you look at this, we see here by age group, by females, so we're trying to look at information by different demographics. If you look among the young ones, the 0 to 14, we saw from prevalence statistics there that 2% of 0 to 14 were living with HIV. And that translates to about 35,000 people, young children 0 to 14 living with HIV. Just keep that in mind. And then we saw that among the 15 to 24-year-olds, it was 2.3% prevalence of HIV in that age group. That translates to about 40,000 people. So in total, those younger than 25 years, about 75,000 of them were living with HIV. So let's keep that in mind. 75,000 of those younger than 25 years were living with HIV. However, when the statisticians were looking to analyze this information by these demographics, trying to look at how many 0 to 14-year-olds were actually on ARVs, the numbers were so small such that those numbers could not be reported. The same thing, the 15 to 24-year-olds, those numbers were so small such that they could not be reported. Now, the absence of information here, it does not mean that there is no one who's supposed to be there. It means that out of 75,000 children that are younger than 25 years, we did not have who were living with HIV, we did not have enough numbers of them being on ARVs. So which means we've got so many young children out of the 75,000 children living with HIV who are not on treatment. And those are our young children who are at school, who are elsewhere, and most likely a number of them don't even know their HIV status. And there's a lot more work that is cut out for us, colleagues. So the fact that there are no numbers here, it says a lot. Okay. Now, again, we remember Sedibeng and City of Johannesburg, where the districts that were among those that had the highest prevalence of HIV. So City of Johannesburg was one, together with Sedibeng, that had highest prevalence of HIV. But the City of Johannesburg, when it comes to people overall who are on ARVs, it's among those that have the lowest proportions of people living with HIV. So we've got the lowest proportions of people that are on ARVs. So we've got districts that have got higher prevalence of HIV, but fewer people who were on ARVs. Again, these are gaps that we need to investigate. These are gaps that we need to address, colleagues. Now let's come to viral load suppression. Okay? It seems when it comes to viral suppression, again, as a country, we have made gains. In 2017, 61.6% of people overall were virally suppressed. And we have made strides. This has improved the overall population viral load level, was at 84%. And in Gauteng in 2017, we're at 55%. This has improved to about 79.7% of people that were living with HIV who were virally suppressed. So this is an improvement. So in the order, we're the 4th province in terms of that order. But what does this say to us? 79.7% of people in Gauteng virally suppressed out of the 1.7 million people living with HIV. It says to us there is a population of about 350,000 people who are living with HIV who are not virally suppressed. And we know, for the first time driving from Polokwane yesterday, I saw the first time the board in Woodmead, that speaks about U equals U. And that's really, at least is something I could see a board that speaks about HIV. Because I haven't seen one for a long time. But the question is, when we've got 350,000 people in a population of 1.7 million living with HIV, 350,000 of them are living with HIV and they are not virally suppressed. And we are saying, if your viral load is undetectable, the chances of you transmitting it to the next person is zero, almost zero. It means in Gauteng, we've got 350,000 people who are living with HIV, whom, if having unprotected sexual intercourse, they stand a higher chance of transmitting the virus. And if you look back, a number of them also would be among those 15 to 24-year-olds who are sexually active, who are not on ARVs, and you can see the disaster that we have somewhere. We're working so hard, putting people in treatment, but we still have a long way to go. There's a lot more work that needs to be done, colleagues, so we can see that our work is cut out for us. Overall, again, looking by different demographic variables, we see that females are slightly more likely to be viral suppressed, marginally, compared to males. It's about 79.9% compared to 79.5% among males. Again, among young people, we did not have sufficient numbers to be able to provide those statistics, but we know that among those young ones, 75,000 of them are living with HIV, but we did not have sufficient numbers of them, of those that are virally suppressed, so that we could be able to report. And we can see that among the older people, the older you get, the chance of being virally suppressed actually increases, and most likely, those are people who started ARVs a long time ago, and they are virally suppressed. So we do need to encourage them to stay and continue taking treatment in the way that it is prescribed. So I think now moving on to different districts again, Sedibeng, again, which was one of the districts that had the highest prevalence, together City of Tshwane, viral load suppression is the lowest. It's among the lowest, I would say. So again, that is a concern. So in a way, that is pointing to us the areas that we need to address and focus our attention to in dealing with the epidemic. Now, my colleague, I think it's Edmo, who's going to come and talk to us about where we are as a province in terms of attaining our 95, 95, 95 target. Thank you so much, colleagues.
Thank you, Kangalani. The Premier's office, various departments, civil society and partners, good morning. I'm going to walk you through the 95 cascades. But before I do that, I mean, the chair of the AIDS Council actually spoke about inconsistencies, and I think, we need to say something about that. If you look at various methodologies, you use the Tembisa model to do your planning in terms of, estimates, numbers, and so on. There's antenatal survey data that comes in, program data, and then there are surveys like the HSRC. If you compare, for instance, Tembisa and the HSRC methodologies, they are all trying to estimate the same thing. Tembisa is a mathematical model that makes assumptions. We call those deterministic models. It's an equation that they actually use to do that. And they actually use some of our data to estimate, parameters to actually estimate those various indicators. If we look at the HSRC survey, we're going out in communities, grabbing a group of people, we draw blood, we actually test for all the things that we are reporting. Is this person HIV infected, yes or no? Do they have AT analytes in their blood, yes or no? And are they virally suppressed, yes or no? So this is actually a snapshot of what we actually see in communities at the time that we actually do surveys. The fact that the estimates may be different is because even if we had to repeat the national survey more than once, we're not going to get the exact same estimate. It is the nature in terms of the methodology that we actually use. So I think that's quite important. And then the other thing is, if you look at our definitions for viral load, the standard in terms of these surveys that in fact you look at 1,000 copies and below, partly limited by the assays that are actually used. When you use dry blood samples, you can only quantify up to a certain amount. So there may be differences in terms of, if you are going to be looking at antenatal surveys and so on. So the key message is here is that, in fact, those estimates should be about the same, right? If there are wild differences, then in a sense, it either means some assumptions are wrong, but in our survey, we are actually looking at a cross-sectional look at what the communities are. And of course, we are trying to be as representative as possible. Kangalani spoke about the survey is national. The more we move on to smaller areas, the estimates become a little bit unstable. For instance, those numbers that couldn't be reported is because we don't have enough numbers. So I thought I would just sort of say that before we go on. Now, in terms of our 95, the third 95 variant suppressed, as I said, we're using 1,000 copies. If you look at people on art, since we actually tested people and we are reporting this based on tests, there are people who may have provided a sample and we tested for viral load, but we couldn't test for art because some was either insufficient or not. So we actually imputed using their self-reported art usage. So when we say self-reported use of art there, the person should have provided a blood sample and be tested at least for one of the tests that you're actually looking at. And then obviously, someone knowing their status, what you call diagnosis, they self-report that in fact they knew that they were infected when we started, or they had analyzing their blood. Now, looking at the 95 targets for Gauteng, the first 95 stood at 85.3%. The target, remember, we're saying we need 95% of people being aware that they're actually infected. So we have an odd 15% of individuals in Gauteng who are living with HIV without necessarily knowing it. If you look at the second 95, it's 86.5, still the target 95. And the second 95 is conditional on people knowing their HIV status, right? If we look at Kangalani's report, the 73 odd percent, if we were going to look at this in terms of population level, that 73% should be sitting at about 91%, right? The difference between the population level 73% should be about 91% if we are actually to achieve the 95. And then the 95%, the third 95 for people who are on art, who are aware of their HIV status is 95%. So once people actually know their status, they go on treatment, they do well. If you look at that, we've actually achieved the third 95, but conditional. But remember, the main important thing is really the population level viral suppression. That's 73%. So looking at 95 in this way, it looks good, but it's not as good. Now, if we stratify it by sex, you find that there are differentials between males and females for the first 95. The gap for females is 5%. The first 95 for females is 90%, whereas for males is 75%. So we are way off, almost 20% down in absolute terms, if you look at males who are actually living with HIV in the province. And then if you look at the conditional second 95, pretty similar for males and females. About 87% and 86% on treatment, and then viral suppression fairly good, close to the 95 and above, or 95 and above for that group. So the gap there really is actually on the first 95 to actually put people on treatment. And then if you stratify by age, as Kangalani said, we didn't have enough numbers to estimate the 25 to 15 to 24. But if you look at the 25 to 49, the rate is 84%, 87%, and 94%. Still relatively low in terms of the first 95 for that group. But for older people who've been, most likely, this is a time issue, right? If you've been infected for long, chances are and then chances are you're actually on treatment. The indicators are slightly better for awareness of treatment, but a bit concerning in terms of art coverage. People who had art analyzing their blood in that age group was 85%. We'd expect it to be much, much, much higher. So the question is, is it because people are not necessarily taking their treatment well? Yeah. And then in terms of the third 95, 94%, 97, close to 98% and 94%. So fairly good once people actually are aware of their HIV status, if you look at age groups. And then if you look by districts, still, most districts, the majority of them are below 90%. except Citibank, which had actually 97%. So very good diagnosis, people who know the HIV status for Citibank. And then if you look at the second 95, pretty good for city of Joburg, 95% of people on ads. Low on city of Tshwane, below 90%, that's 89%. And then Citibank, and Ekululeni, and in fact, Citibank is actually quite good, almost close to the 90%. So Citibank is doing fairly well on the first two 95s. And then if you look at viral suppression, pretty good all the provinces, and fun enough, Citibank, although they are doing well on the first 295, they're not doing as well in terms of viral suppression. Sitting at about 90% or just below 90%. Now, another way of looking at this, in terms of gaps, is if we're saying people need to know their HIV status, then we can ask who is that, which groups are those who are actually not diagnosed or who are not aware of the HIV status, who are living with HIV. So we profiled, in terms of age groups, 3 age groups, 15 to 24, 25 to 49, and then 50 plus. And then we said, what's the proportion of that specific group that contributes to people with living with HIV, right? So the first bar says we have 6.8% of people 15 and 25 contributing to the whole pool of people living with HIV. And 66% were individuals 25 to 49, and then 27% 50 plus. Right? So the first bar basically says, what's the contribution of people living with HIV in those various age groups? Now, if we then go on and say, of those people living with HIV who are not aware of the HIV status, what's the proportion of each group? So effectively, we are saying if there were 100 people who are not aware of the HIV status, 20 of them were aged between 15 and 24. And 62 of them were aged between 25 and 49, and 18 were aged between 15 years and older. Now, proportionately, we should expect, if everyone was actually behaving the same in terms of knowing their status, we should expect about 6.8% of young people to know their HIV status. To be unaware of their HIV status, right? But in this case, they are contributing 20%, almost a threefold in terms of the pool of people who are not aware of their HIV status. So young people proportionately are not diagnosed. They are living with HIV without knowing it. And then if you move on to people who know their HIV status but are not on ART, young people contribute 14 out of every 100. Right? So proportionally high, almost twice as much compared to people living with HIV. And then if you look at viral suppression, still that proportion is high if you're looking at young people. So young people are not doing well in terms of being diagnosed, being on ART, as well as being virally suppressed. They contribute proportionately more than what's expected. And then if you look at in terms of we did stratify by urban areas, rural, formal, or what we call tribal areas, and then farming communities. And also bearing in mind that, in fact, when I talk about these numbers, when we talk about people not knowing the HIV status, it is a relatively big number. Kangalani spoke about, I think we're talking about maybe 150,000 people that are in that group. If you look at stratifying by location, we find that in fact Gauteng is predominantly an urban area, which is expected. So most people are actually living in urban areas, about 90%. But the interesting thing is people who are said to be living in rural, informal, or tribal areas, they contribute 7% of all people living with HIV, but they contribute a disproportionate higher percentage, which is 12% of people who are not aware of their HIV status. And they also contribute about 12% of people who are aware of the HIV status but not on ART. And they contribute 10% of people who are not virally suppressed. So the challenge there really is individuals who are staying in what we're calling tribal and rural areas. I'm going to ask my colleague to come and talk about the drivers. But just to say, if we think about Gauteng, it's a migrating province, right? So the issues here, if we talk about the changes in treatment, test and treat 2015, 2016, Gauteng is not doing as well as testing people and putting them on treatment. And the question is why? Is it because they're very diverse, province? Is it because they're migratory province? Those are some of the things that we need to talk about. And the behavioral issues, I guess, they may actually help us in trying to understand those issues. Thanks.
Good morning to you all, both online and on person. Oh my gosh, in person and online, sorry. My name is Gutlanos Kosana, and I am the Gauteng Provincial Coordinator for the 6th SABSSM, and I'll be taking you through the key drivers of the HIV epidemic. For sexual debut before the age of 15 years, among youth aged 15 to 24 years by province, the results are as follows. Nationally, early sexual debut decreased from 13% in 2017 to 11.2% in 2022. Gauteng also saw a decrease in early sexual debut from 14.8% in 2017 to 13.2% in 2022. When looking at early sexual debut in the province by sex, locality type, and district, the results show that more males were engaging in sex before the age of 15 years compared to females, at 17.8% and 7.9% respectively. Early sexual debut was higher in urban areas at 13.4%, and early sexual debut was also higher in the West Rand at 18.1%. For multiple sexual partners in the last 12 months among people aged 15 years and older, the results are as follows. Nationally, the proportion of people aged 15 years who reported having multiple sexual partners and older, so this is 15 years and older, decreased from 10.8% in 2017 to 8.9% in 2022. In Gauteng, the proportion has notably decreased from 12.8% to 7.8%. Additionally, while the Gauteng percentage in 2017 was above the national average, it is now below the national average. So I think that's good. When looking at the proportion of people aged 15 years and older by sex and age group, the results show that the proportion was fourfold higher among males compared to females, while those aged 15 to 24 years had the highest proportion at 17.1%. By district and locality type, the proportion was higher in the city of Tshwane at 13.7% and 19.7% in rural or tribal areas, which was the highest of all the localities. For condom use during the most recent sexual encounter among people aged 15 years and older, the results are as follows. Nationally, the use of a condom during the most recent sexual encounter decreased notably from 39% to 31.8% in 2022. Similarly, there has also been a decrease in Gauteng from 36.3% to 30.3% between 2017 and 2022. When looking at the consistency of condom use with the most recent sexual partner, the results for Gauteng show that 53.8% of the respondents never used a condom with the most recent sexual partner, which is more than double the proportion of respondents who reported using a condom every time at 20%. The district level results show that 58% of respondents in the city of Tshwane never used a condom with the most recent sexual partner, followed by 55.2% in Ekurhuleni. Contrastingly, these districts report low consistency of condom use with the most recent sexual partner, with 17% and 19.1% of respondents in the city of Tshwane and Ekurhuleni respectively having never used a condom with the most recent sexual partner. For self-reported circumcision among males aged 15 years and older, nationally, male circumcision has increased from 60% in 2017 to 63.7% in 2022. Contrastingly, however, is the decrease in male circumcision in Gauteng from 64.4% in 2017 to 64% in 2022.
By age and locality type, male circumcision in Gauteng was lower among males aged 25 to 49 years and lower among those residing in rural or farm areas. By district and age group, male circumcision was lower among males aged 15 to 24 years in the West Rand at 60.4%, and also lower among males aged 25 to 34 years old in the city of Johannesburg at 70.1%. For self-reported circumcision type among males aged 15 plus years, the self-reported medical circumcision in Gauteng stood at 70.6% compared to 28.7% who had reported getting traditionally circumcised. When looking at self-reported circumcision by age group and locality type, the results show that 84.4% of males aged 15 to 24 years were medically circumcised, compared to 53.5% of males aged 50 years and older who were medically circumcised. Additionally, 71.8% of males in rural or tribal areas were medically circumcised, which is closely followed by 70.7% of males in urban areas who were medically circumcised. By district, the city of Johannesburg had the highest prevalence of medical circumcision at 76.8% compared to the West Rand, which had the lowest prevalence at 67.4%. Regarding the awareness and uptake of pre-exposure prophylaxis, otherwise known as PrEP, among people aged 15 years and older, the results are as follows. Overall, in Gauteng, 33.3% of the respondents had heard of PrEP. 4.6% had taken PrEP before, 1.5% were currently taking PrEP at the time of the survey, and 65% reported that they would consider taking PrEP to prevent HIV. By district, the proportion of those who had heard of PrEP ranged from 23.1% in the West Rand to 43.5% in Sidibeng. The proportion of those who had ever taken PrEP was lowest in the city of Johannesburg and highest in Sidibeng at 2.4% and 6.8% respectively. The proportion who were taking PrEP at the time of the survey ranged from 0.6% in the West Rand to 1.7% in the city of Johannesburg. The proportion of respondents who said they would take PrEP to prevent HIV was lower in the city of Tshwane and higher in Ekurhuleni at 58.6% and 72% respectively. And finally, HIV testing among people aged 15 years and older by age groups. The results show that 31% of females aged 15 to 24 years had never tested for HIV. Among their male counterparts, however, 40.7% had never tested for HIV. Among females aged 25 to 49 years, 5% had never tested for HIV, compared to 13.1% of males in the same age group who had also never tested for HIV. And lastly, among females who are 50 years and older, 19.1% had never tested for HIV, while 23.9% of males within the same age group had never tested for HIV. So thank you very much. I'll now hand over to Dr. Rachel.
Good morning, everyone. Morning. I'm Dr. Rachel Joseph from CDC. And in these final few slides, I will take us through some of the highlights from today's presentation. These are not exhaustive, but really aim to get us started with the dialogues later on today. So we'll start with some of the promising signals. The first is that we have seen this shift in the HIV epidemic curve towards older age groups. And this signals a stabilizing HIV epidemic. As Prof. Zuma explained earlier, this is what we want to see. As ART coverage is increasing, we see fewer new infections, especially in the younger age categories. And we also see that people on treatment are able to age into some of the older age groups. So this is a great sign. Additionally, we've seen considerable improvement in ART coverage from 56% in 2017 up to 73% in 2022. This speaks not only to the incredible impact and effort of the HIV program in Gauteng, but also to the remaining work to be done. So moving on to that remaining work, despite this incredible progress, disparities in the burden of HIV by gender remain, with a higher, approximately 1.5-fold higher prevalence of HIV among young women, aged 15 to 24, and older adult women, 25 to 49 years, as compared to males of the same age. We also see that ART coverage in 2022 was substantially lower in men at 64% as compared to women at nearly 78%. This is a huge gap. Viral load suppression was lowest, and this is in the population. Viral load suppression was lowest among youth and adolescents aged 15 to 24 years at 67%. And this largely reflects gaps in the continuum of care, as Edmore pointed out, in terms of knowledge of status and uptake of ART, that these persist for people of the younger age groups, for both men and women. On the prevention side, we've seen that the prevalence of circumcision among males 15 to 49 at less than 70% falls below the national target and varies substantially by district. And then finally, PrEP awareness at 33% and uptake at 4.6% was universally low across populations, across districts. But very importantly, willingness to take PrEP was actually quite high at about 65%. So this highlights an opportunity to really optimize PrEP as a prevention strategy, given the willingness and demand in Gauteng. So some actions for consideration, and again, these are not exhaustive, just places kind of to start with the dialogue, stemming from some of these conclusions. The first is that there needs to be consideration, long-term planning, a strategy to care for individuals in an aging HIV epidemic. These are individuals who may, as they age, acquire other comorbidities that also require management, and also the support that's needed for individuals to stay on lifelong ART. This is critical. There's also a need for heightened focus on campaigns such as U=U. We heard this from Ashley's remarks, from Professor Zuma's remarks as well, and other strategies to promote demand for ART, as well as to support people to sustain themselves on ART, especially among young people and adult men. Additionally, we're all here today. There's an amazing level of expertise in the stakeholders here today. This is an opportunity for us to critically assess and address some of the district-level gaps that we've observed in the data around HIV prevention, care and treatment services, and to ensure that everybody gets the care that they need. We need to enhance HIV prevention efforts that target the groups disproportionately affected by the drivers of HIV infection, such as women, and again, back to the youth. We also need to focus efforts to increase coverage of male circumcision, falling below the national target, and continue to engage with traditional houses, leadership, and practitioners to ensure maximum health benefits among circumcised men. And then finally, we need to look at ways to enhance accurate public awareness, but not just the awareness, the demand. The demand for effective HIV prevention measures, including HIV testing, condoms, and PrEP. So with that, I thank you very much for your attention and for joining us today. Thank you, everyone. Hey! Let us also thank, these are the field workers who were out in the field for months at a time, away from their families and loved ones. Let us please appreciate the field workers who made all of this possible. An amazing, amazing team. And then finally, this work would not be possible without a consortium of partners, the US Centers for Disease Control and Prevention, the South Africa Medical Research Council, SAMRC, the National Institute for Communicable Diseases, NICD, University of Cape Town, the National Department of Health, the South African National AIDS Council, the United Nations Children Fund, UNICEF, and the United States Agency for International Development. Funding source was the President's Emergency Plan for AIDS Relief, PEPFAR, through the Centers for Disease Control and Prevention. Again, thank you so much for your attention today. And let's give one final round of applause to the HSRC team for their legacy of providing essential data on the HIV epidemic for the people of South Africa. Thank you.
Thank you so much indeed, Rachel, but also to the HSRC team, along with CDC team that have prepared these results for Gauteng. So this is your results, colleagues. It's the results that you need to receive and also reflect on the gaps. You've seen where you are doing well. You also need to look at where do you need to strengthen. So it's very important that we use this opportunity to look at what is it that we need to do and how do we achieve it now that we know where our shortfalls are or where we then need to direct more energy into, but also not forgetting to continue to work and ensure that we stabilize and continue to support where we're doing well. So we are going to work in groups, but before that, we just want to give you an option to stretch and also have tea. So we'll just have 15 minutes where we allow you to then go out, have tea, stretch, interact with others, just release these yos that I've been hearing. And the shock, the surprise, but also a bit of celebration here and there. Then we will come back after 15 minutes. You go back to your, where you are you are seated, and then there will be a team HSRC person that would then guide you in terms of how do we really ensure that we are guided in how we discuss and reflect more on the findings. There are questions that we will be responding to as well. So please have a bit of a stretch, a break, have a tea, whatever that is outside, interact, and let's come back to continue the good work. Thank you so much.
It's exactly 12:30. Colleagues, we agreed that we will reconvene at 12:30 to take feedback from the groups. I have a colleague here, Kabiso, who will be walking around with the mic, colleagues. Please do select your rapporteur, and Kabiso will then share the mic with that person to give us feedback. Which group is going first? Are you ready? Okay. Kabiso, kindly, yeah. The rapporteur kindly indicate the question you guys were responsible for, and then just take us through your engagements. Colleagues, can we kindly cooperate? The report backs are about to be given. Colleagues,
Can I start? I want to stand up. How about Okay, colleagues, we were doing question number 2. The first question was what HIV messaging is critical to communicate and to whom. So we started by identifying the correctional services. So we say that in correctional services, excuse me, in correctional services, we have a lot of young inmates who are users, and then we have some who come in and then they end up being users. And then the issue there is that the sharing of needles leads to HIV infection in correctional services. And then the messaging that the key messages that we are conveying, we said that we'll be doing awareness on HIV, whereby we are educating them that sharing blood, we know that they use Bluetooth. I hope most of us we know, because we have somebody who said they don't know what that is. So I hope we do understand that they share their blood. You know, I take my blood, then I give to her. So in that way, it also makes the HIV infection to go up. And then also the other key messaging is going to be on substance abuse, because we know that in the correctional facilities, they do use substances. And then the other messaging is that we're going to have partnerships within the correctional facilities, whereby partners, they need to assist with the messaging within the correctional facilities. For example, we identified Sankam, lay counselors, and then there was an issue with having NGOs to supply with injections, but then we ruled that out because of, to start with, using substances in the correctional services, it's a contraband, so that route is not going to work. And then the last messaging there that we identified, it was on adolescent and youth-friendly services and youth zones inside the correctional health, correctional services. And then the next question is that how do we reach and empower adolescent girls and young women? And then where should we focus and how? We identified school health services, the adolescent youth-friendly services, social media, using BYs, social gatherings, and then we identified that in festivals, taverns, whereby we need to ensure that there's condom distribution during the festivals and in taverns, because we know that most of the young people, they go to parties, you know, so we need to go where they go, you know, but the most important thing is it's going to be on condom usage, and we're distributing condoms. And then the other point is that influencing school health policy so that it can allow the department to distribute condoms in schools, because of currently we know that the school health policy, the SGP things, you know, they won't allow partners or the department to go to school to distribute condoms in schools. And then also the last point, we said we also gonna be having dialogue activations campaigns in how to reach areas. And then the next question is that how do good role models in younger groupings influence behavior? So this one, it was a bit difficult to come up with the answers, but we identify that through social media, having seminars, youth seminars, and then also civil society, whereby, during their civil society, the youth sector for civil society, we can invite the role models to come and empower the youth and to influence their behavior. And then also we said that during economic empowerment events, we can have the role models. And then the last one, it was, has you been successful in the province? Here we said, no, UNU has not been successful in the province because of the UNU. We know that it speaks to the last 95 target, and currently as a province, we are on 70-something. And then what could be done to further UNU campaigns? We said that integration with other stakeholders, educate clients to stay on their medication, so that their viral loads can be suppressed. Those who have suppressed, they need to maintain that. And then also blood testing, it should be done on a regular basis. They must not miss their appointments, so that necessary tests can be done to detect the viral load. And also we said that being faithful to your partner, and then also using e-labs. Okay. I can also using e-labs so that we can be able to track and trace those who are lost, to follow up. And then the last point is that currently in Gauteng, UNU was launched in COJ in 2022, and then all other districts are expected to launch by 2024. So currently we have been having ongoing meetings with the district and all other relevant stakeholders. Thank you.
Thank you so much, Table 2, and thank you for the report, Lebo. So we will be moving to the table on my left. Who is the rapporteur? Kindly do not repeat what has already been reported, just for the sake of time.
Okay.
Thank you so much.
Is it morning? Morning, colleagues. I'll make sure I follow the instructions. So from group 1, we did. Okay. From group 1, we did the first 3 questions, but we decided to divert from question C because it's been a repetition for group 3. So we decided to have our own question for group 3, for question C. So the implications of shifting pattern of HIV prevalence and aging epidemic, the response was that we need to strengthen the UNU implementation to ensure that there's less infections and the older populations as they live longer while the treatment, there is a need to address the age-related health issues, including the comorbidities. As you grow, so you get your diabetes or your high blood pressure, and there is a need to address, we need to have ambassadors and peer educators and ensure that we promote the UNU, and we also need to support our elderly on the treatment literacy through the old age homes, as some of them, they're staying in old age homes, so we need to support them there, and also use the warboards as they go to door, assisting our adults, and we also need to use our faith-based organization, our churches on these issues. And the second one is where do you and your children or community learn about HIV at school? Nowadays we've got the 2000 that have got social media that they are using on daily basis, the multimedia, the TV. In the past days, we used to have Sister Bettina's show, which is no longer there. And parents must also be open to their children which is one of the, some kids they feel it's a taboo, or some parents they feel it's a taboo. But now we need to change the messages. The messages that we had in the past is no longer catchy to the young ones. So we need to try to come up with better messages, and we need to have peer educators for our youth, because sometimes they don't feel comfortable to talk to the adults. And we also need to have some call centers for the youth where they can have a one-on-one session with their peers, and they'll be able to get some information on sexual education. And we also need to use our faith organization, especially the young people, the youth clubs, the youth churches, and be able to talk to these issues. And also try to utilize the youth month, try to educate our youth. And the last question that we had, it was why condom intake is very low in South Africa. Maybe one of the most important thing, we had an issue with the national tender for condom distribution. So somewhere, somehow, there were months where we did not have condoms in the country, so which also affected the usage of condoms. So people decided not to use condoms, but again, that's not really the main reason. But the interruption really affected us a lot. And there's a need for HIV prevention programs integration, especially using PrEP. And we should also promote the condom usage, because even if the condom is there, but if people do not promote the condom usage, and we also want to go back to the basics, especially with the health promoters that are based in our facilities on the condom distribution. Sometimes we take things for granted and think people they know, but going back, doing that session, it also reminds people on how to use the condom. And we must also try, I'm not gonna go back to the school policy, because it's also one of the contributing factors to say our youngsters do not have access because of the policy. And we must also try to address the stigma around condoms. And for example, as a mother, I'll go for a conference, come back with condoms, so now I must explain to my partner, where was I the whole week? And also try to promote people to carry condoms, because they'll really be protecting themselves. Thank you.
Thank you so much, table 3. Kabiso, I think table 4 is ready. 4. Is it 6? Please go ahead. All right.
Good morning. Ours was number 2, where the question was saying that how do we reach and empower adolescent girls and young women, where our focus should be based, and how do we do all of that. And we then answered to say that through media and communications, and PR as well, where social media is the lead due to analytics as to where young people actually engage the most. Then that's when we then draft our information in an infographic segmentation, such that it is appealing and it is engaging to young people, so that they can actually take interest into such information that we disseminate to them. And then also, we also thought of creating communities online, accepting the fact that most people, especially the young people nowadays, they spend most of their time online. So we need to take serious about the fact that there is community online, even though when we do our door-to-door social mobilization and all of that, but taking into cognizance the fact that the online engagement is one of the most prevalent engagements in our days. And also we then thought of meaningful youth engagement, where we don't only say we include young people, but we make sure that they also participate, because inclusion alone doesn't necessarily mean that people will participate. So we then design our dialogues in a Socratic way, in such a manner that we have focus group discussions where young people are actually able to state and say that this is how they feel to be engaged, and this is how they feel about whatever that we are bringing to them. And then we also said that we would want to engage departments, because the departments, especially public institutions, let me not say departments, public institutions that are responsible for young people, they should have charters that speaks to the messages that speaks to young people. For example, we launched the Law and Human Rights Charter in the ATB conference in Durban. That charter should be in every public institution where young people visit. It should tell them about the news that they need to hear about the fight against HIV, TB, and STI in South Africa. And then we then said now, where should we focus? Where our focus should be. We said our focus should be on the correlation between the pandemics, syndemics and epidemics, because we want to speak to addressing HIV, TB and STI, also taking into cognizance the fact that there is gender-based violence, which is also the contributing factor to people actually acquiring these diseases. We want to speak to this, saying that there's also other epidemics, outbreaks that could actually affect their immune system. So why is it important for them to be retained on medication? Because we also know that there's medication fatigue that is happening. So not everyone who's not taking medication has not yet started to take medication, but along the way, people also then get tired. And also we said we can't speak about ensuring that people take medication or in fact community development without speaking about self-empowerment and economic empowerment. So in our meaningful youth engagement, those three terms should go into each other, because people must know how to make means to actually stay on treatment. And then the how part was stated, I won't repeat for the sake of time, but it was just policy reviews, that we need to work on policy reviews, ensure that the implementation is done, because we are good at writing as a country, but when it comes to implementation, we are not so good. And then also to have advocacy officers, advisors in this institution. That's the how part. In schools, for the AYP, there must be AOAs that would advise children in schools. In hotspot areas, in communities, because we have an adolescent young people that is in school and an adolescent young people that is out of school. That's why we also need to have AOAs in hotspot areas where young people are situated, in soccer clubs, in soccer grounds, all those places. We must have people who are preaching the same gospel that we are preaching here today. And then also just to visit our orientation curriculums in school, and then also start reaching out to child held at household, because in such household there is no a parent to give proper guidance. And also in so many cases you'll find that the children end up doing a lot of other things as means of survival, which put them at the risk of acquiring these diseases. So we need to reach out to them, and I was hoping to see it on the statistics there when the research was being presented that they've reached out, but when they said household, I believe that it was not covered in those households. And then I think I'm done with number one. How do good role models in young groupings influence behavior? Before we focused on good, we just started with looking at role models. And we understand that not every childhood in South Africa grew up having somebody to look up to. Some grew up having somebody not to look up to. So we then understand that if government can actually hire influencers to promote them during elections, then they can hire influencers to promote the gospel that we are preaching here today. That was the first one. And then we said that we will then use communication trends to communicate the issues of you is equals to you, just like how the youth sector did with the Zikhala kanjani ungavaccinated. We can also say imnandi ngekondom. We then said that we would use young people as ambassadors, because I think that's why we had this term that we've been using for so long, peer-to-peer engagement. Iyazwakala ngempela when it comes from a young person to another young person, and also having them as ambassadors that would actually help suppressing the viral load and also decreasing the new infections. I think I'm done now on number 2. I will move to 3. How great. As you as you've been successful in the province, I think it was also stated here, it was not, because it was only launched in one district. So we need to launch it at the province, because we cannot, but activities are happening. where we speak about the U is equal to U. But without having a proper launch, it also hinder our processes of implementation, the rollout of the U is equal to U, which also it means that we also play with the leaders and delegates who actually attend such spaces to make sure that they don't keep the information to themselves, but they take it on the ground, because there's so much information gaps from the information communicated at National Department of Health to civil society to member organization to a person at the ground level. That information that started there may get down there totally broken. So we need to ensure that we keep accountability and we serve as we said that we will serve. Take it exactly like how we had it and put it on the ground for people to use it. And then also we said that the U is equal to U would be successful if it also being rolled out in contact sports in South Africa, making boxing as an example. People who are playing a boxing when they are HIV positive, we are well aware that they get disqualified. They can no longer play and the career is ruined. And we are saying that we are trying to do this thing. We need to also self-empower those people, make sure that they become the ambassadors, and make sure that they are retained on medication so that they can come back. We are also trying to make sure that people's careers are sustained. And I would say that because I'm from the law and human rights sector and I don't want people's right to be violated. And then also just to ensure that we've got IEC material that speaks to this, as said before, being in all the other institutions and hotspot areas in communities, then we would win. Thank you.
Thank you so much. Very comprehensive, but straight to the point. Thank you. Next group.
Thank you, Chair, and good afternoon to everyone. I think with us, we were supposed to respond to the third one, which talks about the strengthening, areas to be strengthened. We diverted, we actually didn't follow the protocol as it is there. The first issue that we had, because whilst we started with identifying the challenges that we thought were there, having engaged with the experts, they told us that no, those things were actually addressed. So the first thing that we said research results of the survey was focusing on 2017 to 2022. And now we are in 2024. So perhaps the survey should be done more frequently. And we also acknowledge the fact that the funders of the survey are international funders. So we saying that if the researchers can reach out more to the funders to do our priorities as frequently as we need them. And then the second one, it was about the access to school regarding the curriculum. We do acknowledge that the school health program, but it limits in terms of the issues that needs to be communicated. There's still a bit of resistance from the teachers and from the parents on how vocal we can be regarding these issues, and we are recommending that perhaps parental engagement should be increased, and so that they should extend what we are preaching right here. The third issue that we also discussed, we were also aware that there are peer-to-peer programs that are taking place. However, we still need to strengthen those areas. We are aware of the bloods, in the higher educations, but more can be done, and I think we did mention about the influences as young girls on that. So if you can have more programs for the youth as well. I think our last one was on the gap in the condom usage. We say that we need more published methodologies for condom usage. If we can get studies that are being done so that we can replicate such studies in our own country. Thank you.
Thank you so much, Dr. Ikalafeng. We need more frequent HSRC reports. From your lips to their ears. Thank you so much. Next group, Tabiso.
Good day, ladies and gentlemen. The person that was supposed to present is not here, but I'm taking over. It's a promotion. So I'm welcoming the promotion. Let me start. What is the messaging? Is critical to communicate and to whom. Communication should be inclusive, not to gender specific. So which means the question is looking at a young girl, but we are saying everybody should be involved. And then targeting population based on age and gender. It depending on the age and gender, the gaps identify its key point population. You're looking at the issues of young girls, you are looking at issues about gogo. Those are grannies, you are looking at issues about LGBTQI family. Identifying areas where they meet, entertain areas, universities, school, churches, and malls. Young people, nabantu abadala batholakala emasontweni, young people bagcwele ema-malls, bayothenga iy'nwele, bayatholakala lapho. And then we also having abanye basey'kolweni, which are young people. So we are looking at those areas. Reach out to the youth, sifinyelele ebantwini abasha. There are programs that we are doing yokufinyelela ebantwini abasha. You know, when you want to have young people, ufaka ne-entertainment kancane nje, and you'll find young people. Strategies to identify where they are most found. So we need to come with strategies. Esizokwazi ukuthi batholakala laphi. With men, sibheke indawo ezinjengama public place, indawo zama-tavern, siyahlala singotata sisele. So siyatholakala kuma-taverns, that's where you can find men. Kuma-barber shops, siyagunda kakhulu ke thina iy'chiko, nazo zonke le y'tayile ey'gunda abobaba, so siyatholakala nalapho where we are fixing ourselves. And then soccer fields, you know, in South Africa, we love soccer very much. So in soccer fields, we make sure that we find men la batholakala khona kudlala khona ibhola, and also taxi ranks. We are also going to taxi ranks where we will find men. And then moving to number 2A, we are saying how do we reach and empower adolescents, girls and young women? Where should we focus and how? Household or family involvement, integration in community with youth. Bayatholakala endlini kufune sispread nasemakhaya, bayatholakala endaweni zama families. Bese ke ithi women gathering access in an issue, accessing is an issue. Ukuhlanganisa nje omama kuba nzimanyana, kodwa ke laba hlangene khona, that's where we should get them. Yeah, kunzimanyana khona ukuthi bahlangane, kodwa bayatholakala bona. Targeted activists that include of elderly population, as they are mostly caretakers. Ukuthola abantu abadala njengabantu kuyibona abagadi ingane nabakhulisa ingane, nokuyibona bona kahle kahle abagadile nje ukuthola bona kakhulu. Do not leave out any gender, including men. So when you are empowering a young girl, make sure that also young men are empowered, so that we are able to have a society whereby everybody is informed, not exclusive of any gender. Have a dialogue led by youth to avoid being judged by parents and other community members. Sometimes, you know, youth will want to listen to youth. So having a dialogue which is directed by youth also is very much important. Create a platform for youth to speak, facilitated by youth. Create a platform where youth will speak, and those platforms will be facilitated by youth. Messaging, you is equal to you states. Informing on HIV spread, prevention, ATRs through social media, dialogues, workshop, traditional advertisement. Mobilization through door-to-door and individuals. So when it comes to issue, you is equal to you, we need to spread to make sure that People are trained. We are using also media platform to correct even the wrong information that is shared through media. Also to use the media platforms and also other the social media platform, because that's where you find young people. Also to do workshop and traditional advertisement. Siyazazi ke lezi ezethu esiyisebenzisayo singabantu to mobilize and to advertise, and we also do that through door-to-door and integration. Siyeke nakuma informal settlement using backyard talks. Siye nakuma informal settlement using backyard talks. That is very much important. I'm told, so I'm trying to read from a very, very, very low position. Not to say I'm not relaxing. Okay, we are also, yeah, it's good now. It is put straight, my team, please don't disturb me. I know I have somebody that is, yeah. We are moving to 2B. How do good role models in young grouping influence behaviors? We have said that certain behaviors are perpetuated by role models from a distance. Also, we said best or idea role models should be from household or families. That's where we find role models, and school and churches. And then influence behavior from home or neighbor. Uma ngabe ke ekhaya a child cannot get influence of a good behavior, uzomuvela to a neighbor, and good neighbor angafika tholo kunye okungekho right. We have made an example of whereby a mother this side is attending church, and a mother on the other side mhlambe kunezinye izinto azenzayo, and umntwana agcine kopha khona ngoba la ekhaya akayiboni into engaba yi-role model. And misinterpretation of modeling, luxury and fashion. Abanye abantwana ke bacabanga ukuthi a role model is something that wears beautiful things, that drive luxury cars and all those things. And if umntwana akachaneliwe right uzolandela lezo zinto lezo, uma engayithola agcina senza into wrong to get them. Social media influence, that's where the problem is. Have you ever seen also even our music is different from our old days? Before people can even sing, there is a different way of wearing or clothing themselves for singing. And ngathi abantwana bayayithanda kangcono. So also bagcina sebethatha leyo nto leyo as opposed to what we know and what should happen. And then bese siya ku social handling peer pressure. That's a big problem. Umntwana wangapha if uyakhona ukwenza izinto, a child from the other side angakhona ukwenza izinto ugcina afuna ukwenza into wrong, azafakwe influence to do wrong things because kulele linye side akatholi lutho. Uma engachanelwanga ngabazali to speak to that child ukumfundisa ukuthi if things are not available akwazi kuba umntwana and remain a child kunjalo. Rehabilitation centers abaluleke kakhulu ke for these children ukuthi also bavama ukuthi abantwana if sebegcina bethatha izinto like they are using drugs and all those things baye kulawo ma programs, especially sifundise na these programs ebekhulunywa ngayo, the programs of the Bluetooth, because also abantwana bethu bacabanga ukuthi it's right, but once they can go to rehab centers and find the right information, they will be able ukuthi basizakale. Ngiyabonga.
That was loud and clear. I think the promotion is well deserved. You should keep it. Thank you so much, colleagues. Kabiso, the next group. Colleagues.
Thanks, Program Director. I think from our side, our report is going to be the shortest because it's actually an icebreaker just to deal with the analysis that of the presentations that were given. We're dealing with question number 1 on what are the lessons learned in the province. Question A was actually speaking about the implications of a shifting pattern of HIV prevalence and the aging epidemic. Yeah, so I think from our side, in us trying to attempt to answer that question, we then said the art program is actually working in the program, in the province, which simply means that hence many people are actually living longer. That means the virus is actually depressed because people are actually not defaulting. So if people were actually not utilizing condoms, if they were not on art, we could have find ourselves in a situation or in a position where the virus is actually not suppressed. And also we know that there is this sugar daddies kind of things that are happening across the province. So if they were actually not utilizing art, we could have found ourselves in a situation where there is a higher infections rate. But because now they are on art, they are not defaulting, they are taking their medication. So we're actually seeing that shift where people, or the spread amongst the aging population, are severe and they are just generally virally suppressed and not able to transmit the virus. Two, the question was saying, where do you and your children or community learn about HIV at schools and clinics? One, we have said one, in schools, there is school health programs, whether through life skills program or life orientation, whichever one you choose to use. There's that LO period where learners are actually learning from their teachers. Two, then there's information that are coming from health facilities, your clinics, hospitals. Three, social media is playing a huge role. We know that many organizations have their social media pages where they share information. Four, we have community healthcare workers that are actually always on the ground, your peer educators that are actually on the ground, engaging young people, engaging our communities. Five, there are campaigns again by civil society organizations, which will then include your faith-based organizations, your youth clubs, and many other civil society organizations that are there that are ensuring that education takes place in our communities. Six, then you also know that we have health promotions campaigns, corner-to-corner campaigns by our health promoters in different communities across the province. Lastly, there is an issue of billboards and flyers that are always, well, maybe it's IC material. So sometimes it's like an IC released to elections only. So that's why we're very specific to then say billboards and flyers so that we don't make that mistake, because other people might think we're not speaking about exactly that. The last question, I think this was the longest question. Have HIV prevention strategies for men been successful in the province? That's one. And what are the lessons learned and the best practices to focus on? On that one, we then said, it's actually not that question where you can simply say yes or no. It's quite a complex question, but in us trying to deal with the question, then said that actually compared to females, there's actually this huge gap that is actually there when it comes to HIV prevention strategies that are relating to men. So there's that huge difference. And these campaigns targeting men will then actually need to be strengthened as they are not effective or enough. And we'll also actually make examples or to that effect. When you get to clinics as an example, there's that attitude that men generally feel coming from healthcare workers. It's something that is there. It's not a room. It's something that men are dealing with each and every time. That thing becomes one of the many barriers that hinders men from receiving services from clinics or whatever healthcare facilities that are there. That's why we're emphasizing on actually not having, that there is not enough programs that are targeting men, especially young boys as well. Because at times we'll then say with old people, it's difficult to teach them some of these things. But when it comes to young people, you know that we have Take a Girl Child to Work, but program that speaks to Take a Boy Child to Work as an example, and I'm making that as a point that speaks to then mentorship. So if you speak about young boys at that level where you are mentoring them at a young age about best health practices, it's easier when they grow up to actually utilize your clinics. But if they grow up in a system where even their fathers, their uncles are not utilizing clinics because of barriers that are forever receiving, then you'll find even us as young people not utilizing services. So in short, we're saying there are no many tailor-made services that are there for men. indeed there is Mina and what do they call it, coaching paylo programs that are there. But many men, I think even in this room, they are not even aware that there are such programs. Then the second part of the question, they were saying, what are the best practices and lesson learned from whatever discussion that we're having? One is that as a lesson, we need more programs that are focusing on men. We need to accelerate and ensure that your Mina campaign and coaching period is known by many men across the province. Three, you need more men that are healthcare, in the healthcare system. You'll know that if you go to any health facility, you will find more female nurses, you'll find more female community healthcare workers. The number of males in the healthcare system is actually quite low compared to females. Sometimes that's one of the things that then becomes a barrier for men to go to clinics. So it's a lesson that is there that we need to then improve on. So one of the things that we're actually seeing is that one of the groups spoke to that issue, that we then need to speak to GDE or the Department of Education to include such programs in our schools. That's a lesson that is there because young people are not getting that information anywhere, especially boys. By sometimes the information that they're receiving it is not proper. So maybe as one of the things, we need that continuous engagement with SGBs, with the Department of Education and whoever stakeholders in education so that they can allow a situation where we're able to engage young people from there, because at least they're in schools that are already organized. Four, then we need to also engage with traditional healers and traditional leaders in our communities. We know that there are people that they are dealing with on a day-to-day basis. There's this negativity and other regressive cultural practices that are there. But if you engage your traditional leaders, if you engage your traditional health practitioners, it's then easier for information to be disseminated. I think one of the speakers was saying, jwale ka bo ntate, we sometimes go to these places, go Mai, go Kai, and all these corners. That's where we think we can get the best health services. And because those people are there and something that is there, it's our reality, it's easier when we then integrate them, we engage them on a regular basis so that at least as and when men comes to those places, they can give them the proper information. So in short, we are saying that authentic masculinity where we are dealing with the progressive or the correct stuff instead of the regressive stuff that we have actually been dealing with in the past few years. I think that was the last point that we just needed to make. Thank you.
Thank you so much, colleagues. On to the next group, Babiso.
Dumelang everyone. My name is Lesego Motlhala. So our question is based on what the lessons we learned in the province. So basically I want to criticize HSRC on not being inclusive of the LGBTI on their report. I guess maybe I'm really focused on myself, and I breathe, I sleep LGBTI, so I need to be inclusive in everything I do. So I felt we were not being part of the thing. I think you explained to me it's general population, but I feel like next time, please use it in the methodology. We are involved and we're here to stay. So based on the questions, the implication and the aging of the HIV prevalence, and we feel like the aging prevalence is dropping for the aging and increasing on the adherence. And another thing that we wanted to do, all our issues we're raising, people are getting HIV based on schools, but I think social media plays a very important part in our livelihoods. I think everyone, even if you're old or young, now we are on WhatsApp, we're on social media with everything we do. Happy social media doesn't have to be Facebook and Instagram. WhatsApp is still social media. So what we can say is, based on the province regarding the lessons learned, we do have your coaching below, and we do have mothers to mothers where people living with HIV are monitored. So regarding men being sustainable about the HIV prevalence in Tshwane, it's being done well with Coach Mpilo. The always is peer-led, so it's man that leads the project, and with the mentors, it's PLHIV MSM lead the project regarding how they need to manage their livelihood through their support group, the national dialogues, the community support group, with they include their families to be part of it. And what I can say is also regarding, Mina, I'm switching. I feel like we've been giving a girl child attention for a very long time. Men needs attention. So I feel like we need to change the role model. We've been doing adolescent girls for some time. So now men are being left behind. As you could see, the stats is showing, the only thing they're concentrating in sex. So we rather move the sex part into education. So we rather change the mindset from being actively being on porn, be actively on what? On education, sustaining themselves, and be able not to concentrate on being sexually proactive and doing naughty things. Like we give girls. What do we do? What did Tinta was a girl child, baby, utlo fall. So you understand, we teach them different love. So you could see that's why they're so evasive while they're growing up. So for role models, I feel like we've been giving a girl child a very good attention. Can we choose the role model? Do a boy child attention. We push the boy child. Now we start building him on Papa Meragon. Can we just say, go with him and see why he's the head of the house? Learn something from him. You understand? Stand being, say, or hustler. What is hustling? Hustling is stealing cars, doing robbery. That's hustling. Because you look at the guy who buys alcohol of 50,000 from a stolen money. We want a man who's very informative to be a very good example in a community and saying, this is what we do. Don't sleep with many girls. That guy, I have 7 girlfriends, 7 cars. It means I have sex with different girls every Monday to Sunday without using protection. We understand that the messaging is start changing. So we need to just change the narrative of saying, hi Baba, we're not doing that. Do it differently. There's a condom use. This is what we need to be faced with. Concentrate on your studies or be knowledgeable. So this is the mindset that we're changing of the role model. So I don't like reading, sir. Everything is just being said as it comes. Regarding to the PrEP and the PEP, I feel the messaging, everyone thinks it's the same thing. So we need to start to educate them more further, because I think they don't understand the difference between PrEP and PEP and also family planning. I think they go in collision. If a young girl, we say to someone, prevent HIV, he'll concentrate on drinking the pill of the PrEP and the morning after pill, but doesn't concentrate on which one is which one. Because I think they do have the wrong information about what is a PEP and what is a PrEP. So we need to start emphasizing on that information. So the last part of things is, no, I think I covered everything that I wanted to talk about. Thank you.
Thank you, colleagues. I think we on to the last group now, if I'm not mistaken. Yes. Okay, please go ahead, Me Onaya.
Good afternoon, colleagues. I'm representing Group 4. And our main question or issue is successes and challenges in reaching youth, women, and other populations. Next slide, please. Where's A? Okay, I think the slides just got mixed up. Okay, this is the first question. How do we better coordinate efforts on health intervention strategies at local level in South Africa? We thought the best way to share efforts, we must identify an issue. So the issue here is that men are not accessing healthcare services as necessary. The intervention is bring services to men's common locations, including public places and the world of work. Expand Coach Impilo model across the province, workplaces, and civil society sectors, so that every sector can promote the model locally and nationally. We are also identifying stigma as one hindrance to men accessing services and other people. Then we identified you equals to you as one potential intervention that can help us deal with that gap. Please move the banner. Working in silos is another issue. And we're saying strengthening the mainstreaming of the multi-sector response will really help a great deal, so that every government department, every NGO, everyone who is doing something on the HIV, TB, STI response can adopt the multi-sector response. We need to find a way of how do we model it, how do we promote it, and how do we educate people to do it in actual sense. At-risk adolescent girls and young women. We think there's some work that is being done. The biggest thing that we need to do is to document what is happening, make it a deliberate effort to share lessons and agree on what constitute best practices and share them. Underlying psychosocial issues, including mental health and substance abuse, address mental health and substance abuse. This is one way that we propose, is that we stop treating disease. We look at the person as a person, and we look at the person as in totality. Try to look at the underlying challenges that the person, or precipitating factors or vulnerability factors, and deal with them in a multi-sector approach. Okay, now I must go back. How do we influence changing patterns of prevalence among adolescent girls and young women? A challenge here is the socio-economic disparities. And we propose that we deliberately come up with, allocate resources, capacitate people to implement socio-economic empowerment interventions. Women dependency on men lead to power dynamics, power in differences. And this will be done by advocacy for addressing and challenging oppressive cultural and social practices within our communities and our country, including in the world of work. Gender-based violence is another issue, and we're saying we need to integrate our awareness, our support and care. So as we promote, as we create awareness about GBV, let us bring an integrated message on where people can get help for emotional, for social, for economic challenges. Because I saw a situation where the 3 girls in their household were reporting to their mother that their father wabatswenya, because they were afraid to say he's sleeping with them. And the mother said, no, there's nothing like that. Until all the 3 girls were pregnant from their fathers, and 2 were successfully motivated to abort, and the one who refused to abort was kicked out of the house. Luckily, with my colleague, we worked out the mechanism, and this colleague who did not bear children adopted that child. There's also an issue of a late release of NAFSAs. When children, the academic year starts and the children have left the provinces or the homelands or wherever where they're coming from to the city where they are coming to the universities, and there's no resources, there's no funds, NAFSAs has not yet been activated. There is a risk that other students may offer accommodation, and this accommodation may be paid through sex, and that sex may not be negotiated to the safe one. Within the informal economy, I've worked in that space for a while, and I've also found that women who work in the corridors, because they come from home from 5 a.m., go to the corridor, which might be 150 kilometers away. If the profits does not rock up, then they don't have enough money for transport to and fro. Then they create plastic shacks. They sleep there. So the truck drivers come, the truck drivers have money, and they are hungry. Maybe they are on the road for 6 months away from home. Then they remember that they are men when they see these women. Then they forget that this is not my woman. They ask for sex and they offer money. This woman who lost income from perished products will find that money handy to provide for her family. Self-centeredness. Working across different African countries, I found that South Africans, we have a lot of people who are very self-centered. I've seen a household whereby when they make soup and they eat and then they don't finish it, they throw it in the drain, whilst another family next door is sleeping hungry. In Malawi, I came across a group of 150 women who were widows. These women decided to start a fruit and veg selling business. Some were cooking, and some of them had small children. Some of them didn't have children. So what they did, they put together their money. They were informal traders. They put together their money on a weekly basis, and they formed a club account. From that club account, they built a crèche. So then they choose among themselves those who can run the crèche whilst they continue to sell the products, and then the leftover products, before they are really off to be thrown away, they donate to poor and orphan children in schools. So in that way, there is a balance of the ecosystem to say, yes, I'm a widow, yes, I may not have children, yes, I'm poor, yes, I'm hustling, but I know that there's another child next door who might be worse off, where both parents might have died. So these women build that crèche, they employ others to run the crèche. The people who bring children there, they pay, and then the women increase their savings, and then they buy cars to buggies, so that when they go to the corridor, they can share transport to go and sell, and they can also share transport to buy big stock from the big markets, and then they make big profit. In Tshwane, we have come across a program by Heartlines. This is an organization which focuses on the church leaders. Then they are running a program called Fathers Matter. This program, they promote social fathers. We are all aware that we have a lot of households where women are the heads of the households. Whether the man died, disappeared, or became unconscious, that he's a father. So in that case, there's nothing that this woman can do to force herself to have a husband or a partner. What we are asking for in this program is that men in the society be the social fathers. When you take your children for rugby game, include the child of a neighbor where the mother does not have a car or even run short of money to take this child to the rugby game. When you take your children out for ice cream, take that other child as well. And there's also a model that I have personally tried, the big brother, big sister social modeling, whereby I have only 2 sons, 38 and 28. And then we raised 12 children in our house. With our public servant salary, we took those children to school with our own children. And 6 out of 12 are graduates. And one of them is a personal banker of our former president, Baba Zuma. So 2 of them in May and June requested me to go and negotiate lobola for them because we remain their parents. And our eldest son took 2 people, young people, to school. One was doing computer science and one was doing information management. The one who was doing computer science was a girl. He went to the college and signed contract and said, I'll pay all the fees. And here is a computer, because you can't learn computer without a computer. And then the other guy was a gardener where he was working. So he always greeted this gardener. And the gardener finally took interest in him, saying, you know, other people don't pay attention to me, but you always greet me. And then they spoke. So this guy said, I also want to be an IT guy. Said, really? He said, yes. He said, go register, look for an institution, I'll pay for you. Then he paid for him and the whole money for the year. And along the way, he was leading a team, and then he said to his boss, please give me 50% of your roles and responsibilities. I want to learn forward. And in 6 months' time, that big boss was going to Cape Town, and he wanted to take him along. He said, no, I'm not going, because I'm already a role modeling for other young people here who think employment is an entitlement. You can be employed, get a salary, and not do your job. So he was literally motivating them. So he remained, and the executive said, so who's replacing this guy who has left? And they were trying to brainstorm, and the big guy said, you are looking too far. There is this guy who was doing the guy in Cape Town's job. He's the next team leader, executive manager of this team. And it was also known that he funded this garden boy to school, and the company refunded him his full money, and he got the 2nd promotion. So this thing is possible, and it's not about having lots of a bank balance. It's about your heart. Open your eyes, see the needs, open your heart, and help where you can. And seeing that we are a community, we know colleagues in other departments. Even though it can be heavy for you, then you make it your responsibility to reach out to social development for them to assist this child, where a shack has burned, where she was living with Mkulu and Gogo. They both died, and the uncle next door is requesting sexual exchange for him to give this child money to go to school and pocket money. In terms of the last slide, how is HIV testing and status of awareness, ART, and virus suppression seen in our community? There's heightened focus on treatment literacy and adherence. Women are a captive and a willing audience for healthcare services. So this is available. What we need to do is to strengthen the power of the response that we get through women. Let us empower women. If a woman says to a child, you can't report your father who's raping you, go police station, because if he's arrested, what are we going to eat? And it's logic. So if we empower this woman, she will be able to comfortably go to the police station, report, and stop the rape, the abuse, and the pregnancy of this child. But that will not be possible unless we empower that woman economically. That won't be possible unless we multi-sectorally respond to this woman's need. In Tshwane, we started what we call an integrated community work model. This model, we bring all the stakeholders, government, NGOs that are working on health and social programs in the community. We piloted it in Region 4 of Tshwane in Ward 106 last year. So there what we did, we firstly established a database of all the service providers. So when there is a case, maybe a woman reports abuse, the person who hears the message first puts it on the platform. There is an NGO that is funded to provide transport to take this woman to the police station. There are NGOs that are funded to provide basic needs like food, clothes, in case this woman runs away without anything on her body. So by the time the transport takes the woman to the police station, the one that brings clothes and pampers for children and purity and something for the woman to eat, others bring the blankets, others start working on the shelter where she is going to go from police station. And at the shelters, there are economic empowerment initiatives. What I've observed is that we lack sustainability. They get trained, they get empowered, but from there, there's not much that can be done. But the much that can be done is for us, for government, for development partners to allocate, deliberately allocate resources that can sustain this woman's dignity, health, and well-being so that she can be alive and remain alive for her children. We thank you.
Thank you so much, Mayor Onaya and team, colleagues. We are almost at the end of our workshop, but before we even go to the next agenda item, which is way forward as well as closure, colleagues, we think it is important that we allow the province, in particular the Department of Health and Wellness, an opportunity to reflect on what has been reported throughout the day, particularly with regard to the SABSSM report, the Gauteng arm of that report. Colleagues, please join me in welcoming the acting COO of the Gauteng Department of Health and Wellness, Dr. Selepe, to the stage so that he can give us reflections on what has happened today. Thank you so much, Dr. Selepe.
I'm not sure if this is working. Thank you, Program Director. Good afternoon, ladies and gentlemen. Let me greet Professor Zuma and the colleagues that work with him, and thank him for the research that he has done, and we acknowledge that it's not an easy work to be done, and we acknowledge that there's a lot of effort that has gone into that research, and also thank the other partners, the CDC, in terms of also assisting, because as a department, that they've conducted between 2022 and 2023. They've clearly provided us with a comprehensive overview of our current state in the nation, and also in Gauteng in particular, where it is our main interest and our focus. While there have been some encouraging signs that they've brought through, like a slight decrease in the overall prevalence of the HIV in our province, but there still remains a significant challenge that we must provide as a province. They've highlighted to us some of the things that we knew, but probably their emphasis on these matters really are of great importance. The city of Johannesburg and Sedibeng have been particularly shown to have a high prevalence of HIV in our province. It is really concerning the numbers that the research has shown us today, showing estimates of more than 500 people in Gauteng that are currently living with HIV, but who do not have, who are not on treatment. And what is also more alarming is that we have so many young people who are not on treatment. And numbers do not lie. And the research is there to show us where the gaps are. What also shocked me was also the statistics that it has been shown that probably we have more than 350 people in Gauteng who are virally not suppressed, which really poses a high and a significant risk to both individuals and the public at large. As a department, we also note the concerns that the older generation tends to be living longer now due to treatment, but really we still have a lot of work in our hands if we cannot control what is happening at the young level with our youth. And also what we really need to look at as a province, I think, is how do we deal with the preventative measures? Because for us to reach 2023, which is around the corner, and meet those targets, we have to ensure that we also put more effort on prevention. And as we prevent, therefore, we are able to be dealing and reducing the number of the incidences that are new or occurring as we move forward. And I think in the discussions today, there's a lot that has been said about how we can really assist in terms of ensuring that we distribute condoms. I think as Gauteng, we can do better. As the Department of Health and our partners, we can do better. We need to come up with strategies that are going to say we are doing things differently. It has been shown that in Gauteng, our distribution of condoms has come down. It has been shown that in Gauteng, the circumcision rate has come down. It has been shown that the people who are aware about the PrEP is very low. And that means, as a province, really we have to put our heads together and say, how do we reach to those people? We know that we have been shown today as well that we are not meeting the 95, 95, 95 targets. And we will not be able to eradicate this HIV unless we get that right. Professor Zuma, these findings about Gauteng Department of Health, as a department, we accept them and we say we are committed to taking decisive and comprehensive actions to address these challenges and to improve the overall health and outcomes of our people. It's been highlighted here that we have to do hard and work hard to enhance education awareness in our community, in both ensuring that people are able to test, people are able to understand what are the preventative mechanisms that can be there, in also ensuring that our people are able to come for follow-ups and we are able to reach the suppression that is above 95% in our patients. And we really need, it has been shown also amongst the discussions here today, that we need to improve access to care, whether it's HIV testing or treatment. And it has been highlighted where the people that we need to focus on, men like myself and young generation that is coming on board. The people who are living in semi-rural areas and those areas like the townships, the informal settlements, and the hostels. We need to make sure that those people, they receive access to care. We need to work on efforts that will make sure that we suppress the viral load. I've already spoken about the preventative measures which, as a department, we are expected really to assist our communities. And we cannot do this on our own. We have to foster partnerships with our stakeholders and the community so that we are able to fight and win this battle. As I conclude, the Department of Health, I've said it's committed to addressing the challenges highlighted by the research presented here today. We recognize that it requires our coordinated effort, innovation, solutions, and strong commitment from our stakeholders as well, including the civil society that is here with us today. Together, we can turn the tide against HIV in Gauteng and ensure that every individual knows their status and has access to treatment. I want to repeat that. We have to ensure that each and every individual that lives in Gauteng, they know their status and they have access to treatment. If we can achieve that, that whoever walks the streets of Gauteng knows their status, just like they know their names. Therefore, we will be able to work, because sometimes, even if people know that treatment is available, they don't know their status. And if we make them know their status. Thank you, ladies and gentlemen, and let us continue to work together. And thank you, Prof, and we hope that we will be getting our next results very soon. Thank you.
Thank you so much, Dr. Slepe. I'm going to call Prof. Kangalani to close for us, but before that, would just like to get your evaluation of the event. We obviously, as he said, he wants us to come back and share results. So when we come back, we want to ensure that we're able to also improve or do what if you think everything went well, it's fine that we proceed as the day proceeded as well. So if you can just take time to just respond to the questions that are on this link, or just scan the QR code there, would really appreciate that. I'm just going to ask Prof. Kangalani to then close for us, and then we'll just provide information in terms of where we will have lunch, so that we continue some of the conversations that we stopped due to time.
Okay, thank you so much, program directors. I just want to reflect on just two issues before I come to the end. One is that of inclusion of key pops, the inclusion of members of the LGBTQI in the survey. One of the issues that I just need to highlight is that this is a household-based survey, and members of LGBTQI are also members of our society, are in the household. And of course, as part of data collection, they also stood a chance of being selected, and also they are part of the study. Now, what also to highlight is that the data that you saw here, it's only a tiny part of information that is contained in the data sets that we have. So there is a lot more information contained in the data set, and I would want to challenge each and every one of you that this data, this is your data. From 2002, all this data is actually curated. It's available on HSRC website. You can go to HSRC website and download this information, analyze it, interpret it, forward it to others, encourage people to use this information, encourage people to download this information, and therefore further analysis could be done to look specifically, for example, among the key pops and LGBTQI, if you want to take further the analysis. But of course, the challenge is that in communities, it always becomes a very big challenge to actually get people identifying, like freely identifying as members of LGBTQI society. So you find that we don't have sufficient numbers of members of LGBTQI communities to actually be able to do further analysis using the household-based survey. But there are other studies that HSRC does that specifically focus on key pops. So I thought I'd just highlight those two issues before I come to really thanking you colleagues so much for your presence here, for your participation, and being part of all these deliberations. Really, as HSRC team, we really want to thank all the partners that are here. We want to thank the Office of the Premier and the team that is working in the Gauteng AIDS Council, for them coming here and also being part of all the arrangements leading to these activities or leading to the dialogue today. And also, colleagues, we want to express our sincere gratitude to all stakeholders. Some were not able to come due to other reasons, but we want to really convey our sincere gratitude to civil society, to our developmental partners, CDC being here. We've been working together them for a number of years, and hopefully we'll continue working together in the next survey. Do I get yes? And CDC knows that a yes means money then. And also, colleagues, want to thank representatives from government departments such as NDOH, social development, education, and also correctional services for coming here. Your engagements, colleagues, today have made a contribution to the work that we are doing as a HSRC, and also contributing to finding and strengthening program towards our collective goal of addressing the drivers of this epidemic, and also ensuring that we are on track towards making HIV and AIDS no longer a threat to life by year 2030. So colleagues, we really look forward to this being a start of our continued engagement, continued relationship, and such that when we prepare for the next survey, we can be able to call on you to work with us to improve participation. Work with us. We are researchers. We can only implement what communities are saying. We can hardly come up with noble ideas, but noble ideas are there in the communities. It is you, colleagues, who will tell us what is it that you need to do differently to encourage those stubborn males so they come and participate in these surveys. It is you, colleagues, who will tell us how do we get those males to the facilities, kicking and screaming, taking them to facilities so that they get tested and know their HIV status. It is you, colleagues, the members of society, communities, who will help us achieve that. And ensuring that those that are in gated communities do not sit back and think that HIV and AIDS and all other ailments are for other people. HIV and AIDS knows no race, knows no age. Everyone is at risk of HIV and AIDS. And therefore, we need to find ways of ensuring that even within their gated communities, they are also part of these studies because they are part of our societies. So we all need to work on those ideas so that when we prepare and put forward the next survey, at least we've got good ideas and make sure that we improve our participation in Gauteng from 60% in HIV, in specimen response, right up to 80, 90%. Other countries do it. I just don't understand why we are not able to reach that level in our country. On that note, colleagues, thank you so much. I don't want to be long. I know I stand between you and lunch, and my colleagues are going to indicate to you where we're going to go from here. Thank you so much, colleagues. And also to thank a round of applause to our program directors here who've just done a sterling job, colleagues. And I don't know, I see my colleague there, a hand, I think he wants to give us an idea of how we can improve response rate in the next survey. Yeah, thank you. He wants to do that.
So that we can be able to further and better the response when it comes to HIV and AIDS. And it's also very important when we speak about research and we're also looking at the most optimal treatment that is actually available, looking at how we can actually take it up so that people can have access. Because we know that for a fact, we do have those treatments, we do have those prevention methods and those diagnostic tools, but they are not being easily accessible in our communities, more especially on a facility level. So man was to say that. Thank you so much.
Thank you so much, colleagues. So I have been asked to inform you that lunch will be served on your right as you leave the hall. That is the first thing. Secondly, those of you who drove here, colleagues, please take your parking tickets to reception so that they can be scanned. Otherwise, you will be required to pay on exit. Thirdly, colleagues, while you are busy in the queue waiting to dish up, kindly remember to assist that with the survey, colleagues. It will assist in terms of ensuring that when we do come back here, things are much more smoother. Thank you so much for being a very cooperative audience. Thanks.